Hello, colleagues. I hope you are doing fine. Welcome to Mr. Coco's Ness's class. If you're not a subscriber, kindly subscribe, and if you're a subscriber, kindly share the information and click like. So, at this moment, we'd like to look at neonatal jaundice. Some other literature will bring to you, say, neonatal. Maybe say jaundice neonatal or just neonatal jaundice. So just have to think like this is the same because they just turn the words or swap the words to say jaundice, then they put neonatal somewhere or neonatal jaundice. So that's what they bring for you. Then if you look at this, say neonatal, so meaning that you're dealing with a neonate. And the neonate, you're looking at these babies or infants, or you can say just babies, 0 to 28 days. So that's the period of time that you're looking at. So you need to be careful with what you do in terms of your nursing care because you look at those 0 to 28 days. What can you do to these neonates? Okay, because it's not everything that you need to do in terms of general care. Okay, so we'll look at that. Then this is a neonate with jaundice. As you can see the color here, the color is yellow. Okay, so the yellowness is what we're concerned about. If you look at the eyes as well, you can see that this baby is yellow. So this yellowness is what we are calling jaundice. So jaundice is about color. So when you look at the color yellow, this baby is appearing this yellow, you would know this is jaundice. If you look at the eyes, sometimes even the mouth, if you check in the mouth, you discover that there is some yellowness or even the skin. So this is what jaundice is about, just the skin becoming yellow. Okay, so even here in our introduction, when we say jaundice, so jaundice is extracted from a French word. So when we say jaundice, comes from a French word which is jaundice. So what does jaundice mean, or jaundice? It's just yellowness. So just looking at like the image above, you look and see the yellowness, meaning that this one is jaundiced or jaundice. Okay, so then where does jaundice come from? So you look at jaundice, it comes from high bilirubin. So if you look at what we call bilirubin, some of you obviously might have seen the bottle for urinalysis. There is a bilirubin there, urobilinogen. So this bilirubin, it comes from somewhere. Now, where does it come from? It comes from bile. So it's a component of bile. Obviously, you know that bile comes from the liver. We'll talk about it. And then it passes, maybe goes to the gallbladder for storage and goes to the intestines. We'll look at all that process. Then this bile here is the one that causes what we call the yellowness in the urine and feces. Okay, and maybe the browning of the feces. So that's the bilirubin. So mostly you discover that the yellowness is the one responsible for the bilirubin is responsible for the yellowness. So you need to just connect these two. Okay, bilirubin and yellowness. So that's the thing here. Okay, then what's the normal range? So you discover that in some of the questions in MCQ, you find that they've asked just about this. They're just looking about they're looking at the normal range. So the normal range is 5 milligrams per deciliter. Okay, that's what they will look at. So say sometimes it may have maybe say they may ask you which level shouldn't it exceed. So it shouldn't exceed 5 milligrams per deciliter. Or sometimes you may look at this to say it's 0.2 to 1.4 milligrams per deciliter. So they will ask you about all this. Sometimes they might say at which level shouldn't it exceed in blood. So it shouldn't be able to exceed 5 milligrams per deciliter. So is it normal to find bilirubin in blood? Yes, it's normal to find it, but it has to have the normal range. So that's the normal range we've given you there. Then what about now the definition for jaundice? So when you look at neonatal jaundice, you can define it in any way that you want, but you shouldn't forget this word, yellowish discoloration of the skin. So the yellowish discoloration, because we've agreed to say that jaundice is all about yellowness. So the yellowness, it needs to come out. So that's why I was saying that it's the yellowish discoloration of the skin, the sclera, and mucous membrane in the newborn. Okay, then if it's that, then what is the cause? So due to the increase or increased levels of serum bilirubin, which is a component of bile. So that's a definition. So you need to put up that. So it's as a result of an increase in the serum bilirubin, meaning serum, we're looking at blood. Okay, so meaning the levels of bilirubin in blood have increased. That's why we have this yellowness of the skin. Okay, then like I told you, when does jaundice appear? So when should an infant become yellow? So like I gave you 5. So 5 to 7 milligrams per deciliter, you expect this neonate to become yellow. Okay, so that's what happens there. Then I've got this word here, connectorus. So you discover that in your completion part, which is section C, they'll be able to ask you about the complication of jaundice. So there may be many. You can have seizures, you can have cerebral palsy as complications. But then they'll ask you about connectorus, which is here. So when they ask you about this, mostly they'll say which complication of jaundice affects the brain. Or they'll find a word to say that as a result of excessive accumulation of bilirubin in the brain, jaundice will result into connectorus, which is the damage of the brain tissue because of excessive amounts of bilirubin. So that you need to note. Okay, yes. Then let's look at the predisposing factors. Let's look at the predisposing factors. Which babies are at risk of developing jaundice? Who is at risk of developing jaundice? So when you look at the infants who are at risk, you can have, say for example, siblings who have had jaundice, meaning that in the family, if your elder brother, or maybe just anybody who's had jaundice before, you may find that it will reoccur into another baby. So they may also have jaundice. So that's the belief which is there. Then another one which is common is prematurity. So in premature babies, you discover that most of them will have jaundice. Okay, we'll talk about it how it occurs in the pathophysiology. So most premature babies also have jaundice. Okay, then where else can you find jaundice? Poor feeding. You may discover that this child is not even a premature, but having problem with feeding. So you may discover that they might have jaundice, or just say poor feeding or difficulties in feeding. So those who might have difficulties in feeding, they might develop jaundice. Then other children who are at risk are those with cephalohematoma. So we'll look at cephalohematoma under birth injuries. We'll discuss that in details, but this is accumulation of blood. Accumulation of blood under the scalp. That's what we refer to as cephalohematoma. So it's accumulation of blood in the scalp. So this occurs because some believe that because of hemolysis, hemolysis will lead to jaundice because of this problem. Then blood type incompatibilities. So we're looking at the A or B or B incompatibilities or ABO incompatibilities. So meaning that you might find jaundice because of hemolysis. And then let's look at now the pathophysiology. Excuse me. The pathophysiology here. So the pathophysiology will be based upon the 5 stages. So these 5 stages are the ones that are responsible for jaundice. So look at the production, meaning where is bilirubin coming from and where is it being metabolized. So what about the uptake in the hepatocytes, in the liver? Then also look at conjugation. Conjugation, it's a word where we say addition of water. So when we look at just conjugation, we're looking at the amount of water added to, say, bilirubin for it to change the state. Okay, so we'll look at that in details. Then excretion into the bile ducts, how does it move? Okay, then delivery to the intestines, how does it go to the intestines? So that's what we look at. So bilirubin we've established to say that it's the one that causes the yellowness. Okay, so that's why we're looking at it. So let's continue. So in our pathophysiology, we're going to look at the first step. The first step we're looking at is the red blood cells, because that's where bilirubin is coming from. So if you look at this here, we're looking at the red blood cells. The red blood cells normally have a lifespan of 120 days, meaning that they live for 120 days in the body. Then they will be broken down, or the word which has been used here, they'll be eaten up by the macrophages, or they'll be broken down. Okay, so this is now where we say the spleen is the one that is responsible for breaking down these odd red blood cells, because they'll become very odd, so they have to be broken down. So when these red blood cells are broken down in the spleen, so the spleen, that's where everything starts from. When they're broken down in the spleen, these odd red blood cells, they will be broken down into what? Things which we're going to mention, okay? So they'll be broken down into the hem and the globin, because we're looking at red blood cells which have also hemoglobin, okay? They have hemoglobin, so the hem and the globin. Then that's when we look at the hemoglobin here, hemoglobin is broken down into 2, hem and globin, because we're looking at hemoglobin, meaning that you're looking at red blood cells. Then what about the globin? Okay, let's look at the globin, because we're looking at hemoglobin. Okay, so let's look at the globin here, this part which we said globin. Okay, so globin will further be broken down into amino acids, because we've got hemoglobin. Hemoglobin, we're looking at a red blood cell. So we've said that hemoglobin is broken down into hem, okay, which is here. Look at hemoglobin is made up of hem and globin. So the globin, which is the last part, is further broken down into amino acids. What about the hem here? Hem is further broken down into iron and bilirubin. So that's the connection there. So the M is there, iron and bilirubin, while the globin is broken down into amino acids. So this is where now the process begins. Just those red blood cells live for 120 days and they become odd. Then they're broken down into the spleen. So when they're broken down into the spleen, the M goes into iron and bilirubin, while globin into amino acid. Okay, so now let's look at the next step. So when we talk about now the what we call the unconjugated bilirubin, okay, so unconjugated bilirubin, So it's a form of bilirubin that is lipid soluble. Okay, so they'll ask you about this, a lot of questions like that. Okay, so when you look at the unconjugated bilirubin, so this unconjugated bilirubin is coming from what we call biliverdin, okay, which is just right above. So it's right above here, the biliverdin. So this is where the biliverdin, this is where we get now what we call unconjugated bilirubin. So it's coming from there, the biliverdin. Okay, so let's check. If it's unconjugated, meaning that the water is not there because it's unconjugated, that's why I was saying it's lipid, meaning it's fat soluble. So they'll ask you such questions maybe in sometimes in MCQ, sometimes in completion, which is section C or section A. They'll ask you to say unconjugated bilirubin means, that would be the question for NMCZ. So you, when they say unconjugated bilirubin means, you're looking at lipid soluble. That's all. Meaning that water is not water soluble. Water hasn't been added. So when it's lipid soluble, meaning it's not water soluble. So meaning that we look at this, it's not water soluble, meaning it cannot dissolve in water. That's what it means. It doesn't dissolve in water. So then, from the spleen there, how does bilirubin now move to the liver? Okay, so from the spleen, bilirubin will have to move to the liver. So that's where now albumin comes in as a transporter. Okay, so bilirubin, that's what I was saying, in the bloodstream binds. Okay, binds, okay, to the unconjugated bilirubin and gives it a lift over, meaning it's a transporter. It will give it a lift over to the liver, okay, from the spleen. So that's where now another issue comes in. We're looking at the transporter. Okay, it helps to lift over, or it helps to transport. Albumin helps to transport bilirubin from the spleen to the liver, so that the hepatocytes, meaning the cells of the liver, can conjugate bilirubin. So what it means is that the albumin takes it from the spleen to the hepatocytes or the liver cells for conjugation. Conjugation means that we're just going to add water, or to turn fat soluble bilirubin or lipid soluble bilirubin into water soluble bilirubin. So when bilirubin becomes water soluble, it will be called conjugated bilirubin. If it's lipid soluble, it's called unconjugated bilirubin. This is the unconjugated, meaning it's fat soluble. But when water is added in the hepatocytes, it becomes what we call conjugated bilirubin, meaning just adding water. So for it to become, or to be changed from water, from lipid soluble to water soluble, there should be an enzyme. This enzyme, which is making it water soluble, it is called uridine glucuronide transferase, which is UGT. Uridine glucuronide transferase. It's an enzyme responsible for converting unconjugated bilirubin into conjugated bilirubin. So you will find this in completion, that's section C. They'll ask you about the enzyme which converts unconjugated bilirubin into conjugated bilirubin. So they also ask you sometimes to say conjugated bilirubin means, so it means that this bilirubin is water soluble, which is here. Okay, that's what it means. So just find that difference. Unconjugated bilirubin means lipid soluble or fat soluble. Conjugated bilirubin means water soluble. So there are two things that we've talked about here. These are the enzyme uridine glucuronide transferase and albumin. We've learned about now those two things, what they do in the body. Okay, so let's continue. So in the pathophysiology, we also are looking at bilirubin, how it's going to be secreted out, okay, from the liver. So conjugated, now looking at now conjugated, because it's water soluble, it's secreted out into the left and right bile ducts and sent to the gallbladder. So we're looking at this conjugated bilirubin. It's sent to the gallbladder. Now when it goes to the gallbladder, this will be stored as what? Bile. So this conjugated bilirubin, when it goes to the gallbladder for storage, it will be stored as bile. So this is why we have bile, the word bile here. Okay, it's stored as bile. So now after having a meal or after lactation, the child has breastfed, what will happen here is that this bile will be now released. Okay, so the gallbladder will secrete or release bile. And where will this bile go? It will move from the gallbladder to go into the cystic duct, then the common bile duct, and go into the intestines. So therefore, that's what I was saying, therefore it will move through the common bile duct. Common bile duct, down there to go into the duodenum, which is the intestines. So through the cystic duct, the common bile duct, then go into the intestines or the duodenum or the small intestines here. So when it goes into the small intestines, then conjugated bilirubin will now be converted into urobilinogen. Urobilinogen, obviously you have seen this as you are doing urinalysis, even in stool it's there. So urobilinogen, bilirubin, which is conjugated, will be converted into urobilinogen by the help of the microbes or normal flora or bacteria in the intestines. So if you can remember very well, we've talked about albumin, which is the transporter. Then we've also talked about the enzyme, which is uridine glucuronil transferase, which is converting it from unconjugated to conjugated. Then we've also looked at the name changing from conjugated bilirubin into urobilinogen with the help of microbes or normal flora or bacteria in the intestines. Okay, so now let's go further. So from there, we are looking at now the changes or the transformation, whereby what will happen to urobilinogen. So urobilinogen will go some changes, which are called transduction, or just some changes, and it will turn into what we call urobilin. Urobilin, which is excreted and is responsible for the brown color of feces. So urobilin is now excreted, so urobilin is responsible for the feces now here. Okay, so from urobilinogen, so urobilinogen will change now into urobilin, which now urobilin turns now the color, okay, to be brown. So and then this is called stecobilin. Okay, so urobilin, we can just say it's called stecobilin. So stecobilin, what's the job? The job is just to make the feces brown, because the feces shouldn't be white, so it turns the feces brown. Okay, so urobilin is actually recycled, so it can be recycled in the bloodstream, and the process can go on and on. Okay, then what is the issue now here when we look at this point here? So we can say 10% of the urobilin goes to the kidney. That's why you find it in urine to say urobilinogen. When you say urobilinogen, you can find it in urine. So 10% goes to the kidney, okay, to be excreted as urobilinogen, and causes the yellowness of urine. So you find that when it's too much or excess, it will cause the urine to be yellow. Okay, So that's the yellowness of urine. So it's urobilinogen. That's the one that you find when you're doing urinalysis, if it's too much or if it's normal. Okay, so just check out there. So this is what we can really discuss here. And then sometimes if it's too much, now when bilirubin is too much in the body, what will happen now if it's not conjugated? So if there's increased levels of serum bilirubin, what will happen in the body is that it will cause yellowness of the skin and the sclera. So meaning that in the bloodstream it's too much, it's elevated, meaning that there will be yellowness of the skin and the sclera. And then this will also go to the brain. When it goes to the brain to damage the brain, we said it is called kernicterus. So that's the complication of having a lot of bilirubin. So it can cause kernicterus. Okay. So let's look at the signs and symptoms. The signs and symptoms, these things come as a result of an increase in the serum bilirubin. So an increase in the serum bilirubin will lead to all this. So that's the rationale that we give depending on the part affected. So why are you able to see the discoloration of the skin and the conjunctiva? So the rationale is that there is excess amount of unconjugated bilirubin in the eyes and the skin. That's why you're able to see the yellowness. Then the child will become irritable. Why is the child becoming irritable? This is because of excessive amount of bilirubin in the brain. That's the rationale. Then why would the child become lethargic? So this is because of the excess amount of unconjugated bilirubin irritating what we call the nerve ganglion, which is in the brain as well. Then another point is concentrated urine, dark and concentrated urine. Why should we have that? Remember we talked about urobilinogen. So when unconjugated bilirubin becomes excess, it will cause the urine to become concentrated and yellow. Then the child will have poor feeding. The child will have poor feeding because this unconjugated bilirubin become too much in the GIT and also in the brain, leading the child to lose appetite and the child will not feed. Then why are we going to have dark stool? Dark stool, remember that we spoke about unconjugated bilirubin or conjugated bilirubin going into the stool. Now if it's unconjugated and it's excess, we're going to look at it to say it's excess, meaning it will be the stool, which is supposed to be brown as normal, it will become darker because the bilirubin is excess in the intestines. So hence the stool becomes dark. Then enlarged spleen. Why should that be enlarged spleen? This is because there is hemolysis and we can say hyperhemolysis, so meaning that the spleen will be enlarged. Then pruritus. Why should we have pruritus? This is because there is excess amount of bilirubin or unconjugated bilirubin in the skin. That's why we have pruritus. So let's look at now the next diagram here. I know this is not the best that you can draw, but you need to learn how to draw the biliary tree. But when you're drawing the biliary tree, do not include these like jaundice classification, the prehepatic things, and all that. When you're drawing the biliary tree, just include the liver, you include the common hepatic ducts, or maybe say the left-right hepatic ducts, then the common hepatic duct, the cystic duct, the gallbladder, then common bile duct, then the pancreatic duct, maybe even the duodenum down there. That's what you include when you're doing the biliary tree, because the biliary tree will come and they'll ask you to draw this diagram and then put a title above. But this diagram was included just to show the classification. Okay, so I'm just showing you the classification of jaundice, meaning that jaundice can be classified. Remember, there's a difference between classifications and the types of jaundice. So we are starting with classification of jaundice, meaning that you need to explain when you've been asked to classify jaundice. So jaundice can be classified as follows. Number one, there is what we call pre-hepatic, which is here. So pre-hepatic jaundice, but you're not going to draw a diagram to classify. You need to explain narratively. So you're going to say number one, pre-hepatic jaundice. So you even start to explain. To say pre-hepatic jaundice occurs because, we're talking about before. Pre is before. So hepatic is liver. So before the liver. So this jaundice is the one that occurs before the liver. So we look at before the liver, meaning that we're looking at the spleen. Okay, so overproduction occurs in the spleen because that's where we said hemolysis occurs when the red blood cells have reached 120 days. So production occurs in the spleen. So you talk about overproduction from the spleen, meaning that the spleen will hemolyze the red blood cells too much, leading to overproduction. Okay, so this bilirubin is unconjugated, okay, and there will be overproduction in the spleen. So that's what you're going to explain here, meaning pre-hepatic. Then number two, which is hepatic now. Hepatic meaning that we're looking at issues to deal with conjugation. And you said conjugation is just the conversion of unconjugated to conjugated bilirubin. Just making it from lipid soluble to water soluble. So here in hepatic, when you're explaining, you're going to explain to say that there will be decreased conjugation. And what is causing to decreased conjugation? Meaning it may be lack of UGT, which is the enzyme that converts unconjugated to conjugated bilirubin. That's what it means here on hepatic. Then what about now the last one? The last one is post-hepatic jaundice. So you need to explain to say post-hepatic jaundice. It means that it can either be obstruction. Okay, that's what I'm saying, extrahepatic or intrahepatic obstruction. It can be an obstruction in the, maybe say, common hepatic duct. That can be maybe there an obstruction, okay, or in the common let me just label there. Okay, so there can be an obstruction there or there, leading to an obstruction in terms of the flow of bowel. So the common bowel duct can block there, can be blocked. Then meaning that if it's blocked, meaning bowel cannot go into the intestines, and that accumulation will lead to an increase in bilirubin. So these are the three classifications that we have: pre-hepatic, hepatic, and post-hepatic. So you need to explain this in narrative form, no need of drawing a diagram. This was just making it easy for you to at least understand. Then we go to another issue that we need to now look at. So we have what we call types of jaundice. So remember, we're dealing with classifications of jaundice. Classifications, we've said pre-hepatic, hepatic, and post-hepatic. Now let's look at the types. The types, we have what we call physiological jaundice, pathological jaundice, and other types can be jaundice in breastfeeding neonates, and another type is breast milk neonatal jaundice. So you can have four types. The first type is physiological or hemolytic jaundice, pathological jaundice, jaundice in breastfeeding units, breast milk neonatal jaundice. That's what we may have. So let's look at the first one, the first type. So the first type is physiological or hemolytic, which is here, hemolytic or physiological. So you may be asked to write the types of jaundice. This comes in your exams where they ask you to write the types of jaundice. So you can write it, you can just select few points which you can write. Okay, so this type of jaundice will occur as normal transitional jaundice, meaning just this is just in the passing. So most neonates will have this type of jaundice because it's just normal and it's just transitional, meaning it's in the passing. It's not permanent. Okay, so what happens is that in this type of jaundice, there'll be a normal rise in the levels of bilirubin. Why is there a normal rise in the bilirubin? Because neonates are born with an HB or hemoglobin which is even 22 grams per deciliter or even 20. So now it has to go back to normal. The hemoglobin, the HB or hemoglobin has to go back to normal, which is maybe sometimes can say 12 to 14, 12 to 16. So to reduce this from 22 or 24, there should be that hemolysis. Okay, so that's why you have this transition. Okay, so the results of increase in the destruction of red blood cells in the spleen, that's what leads now to jaundice. Okay, that's what we have there. Then hence, if the amount of bilirubin increase, what will happen now? Okay, and if hypoxia develops, what will happen? There will be the efficiency of hepatocytes. Okay, meaning that the activity will reduce. That's what happens. The activity will reduce in the hepatocytes. So this sometimes you may not even write it and all that, but what you're going to write when you're looking at physiological jaundice as a student, you're going to really look at this as a characteristic. So they will even ask you to say differentiate between pathological jaundice and physiological jaundice. So the first one that we have established here to on the characteristics is that physiological jaundice is just normal and transient. Like above here, we're saying that it's normal and transient, meaning you are going to differentiate between physiological and pathological. So this is normal and transient. Then when does it appear? So this is very important. Appears after 24 hours. So this is what you're going to find, even in MCQ or even just maybe completion section. So you're going to find that this question will come, when does physiological jaundice appear? So it appears after. So mark this word after 24 hours. Then they also find out the serum bilirubin level, it will exceed, maybe if it exceeds 250 millimoles or 15 milligrams per deciliter, that's when it will appear as jaundice. That's when the child will become yellow. Okay, so then other things will be here about when is it not detectable, when can you not expect to see jaundice, which is physiological jaundice. If physiological jaundice is present, you don't expect to see it after 14 days. You do not expect to see jaundice after 14 days. So this is another characteristic. So you need to look at these characteristics. It's a normal transitional jaundice, meaning it's in the passing, appears after 24 hours of age or after birth, then never exceeds 250 millimoles. So it will never exceed 250 or 50 milligrams per deciliter. So this is a point. Never exceeds 250 or 50 millimoles. Then not detectable after 14 days. Then in terms of treatment, it will disappear without any treatment. So this is it here. It will disappear without any treatment. Then the baby is okay. So that's another issue. The baby is okay. So just mark those, and those are the ones that you'll be using to differentiate. Okay. Then what about the causes? So the causes just follow the stages in the pathophysiology. So the causes were saying that this is just a normal hemolysis. And where does hemolysis occur in the body? It occurs in the spleen. Remember, that's what we discussed. Then this is just normal hemolysis. That's what causes it. Then Another cause would be short red blood cell lifespan, less than 120 days. That's what happens. Another cause would be liver immaturity, meaning that this can happen maybe in maybe say prematurity, whereby there is insufficient production of uridine glucuronidtransferase. Okay, then another cause will be lack of normal flora. Remember, we talked about normal flora in the intestines. So lack of normal flora in the intestines will lead to jaundice. Then also we looked at albumin. So when there is insufficient albumin, the transporter, remember, you transport unconjugated bilirubin to go to the liver for conjugation. Remember that we spoke about it. So just that lack of bilirubin will cause jaundice. Okay. Then let's proceed to another type. The other type that we're looking at is pathological jaundice. Pathological jaundice, that's another type. Then if we're differentiating it from physiological jaundice, which they'll ask you definitely to differentiate, will be, let's look at the appearance. So when we look at the appearance, when does pathological jaundice appear? Meaning pathological, there's a problem. Physiological, there's no problem at all. It's just a normal thing. That's why it's physiological. Now when we look at issues to do with pathology or pathological, meaning that there is a problem. So meaning that there is a problem. That's why it's called pathological. So pathological jaundice, here we're saying that it appears when within 24 hours. Pathological appears within 24 hours of birth, while physiological, we agreed to say it appears after. Okay? So then, if you look at it, there'll be a rapid increase in serum bilirubin from that's about 85 millimoles to 200. Okay, so meaning that it has to exceed 15 grams per deciliter. That's what we have agreed. Then why should somebody have pathological jaundice? Meaning that they're having pathological jaundice because there is an underlying cause. Okay, there may be an underlying cause, meaning there is a problem there. Is it an obstruction? Is it an infection? Or what could be the cause? So there should be a cause. Then what about the characteristics? So if you're comparing it with physiological, the characteristics are that it will appear within 24 hours. So a child is born today at maybe 02. Then at 04, it becomes yellow. So just know that this is pathological. Then it will exceed, serum bilirubin will exceed 15 milligrams per deciliter and above. While when you look at physiological, it does not exceed, it does not go above 15 milligrams per deciliter, but in pathological, it goes above 15 milligrams per deciliter. Then when does it occur? It occurs as a result of an infection, which we're calling sepsis. Okay, so it may occur as a result of an infection, or there's a problem there. So that's why it occurs. Then the type will persist after 14 days of life. If you look at physiological, it said it does not go beyond 14 days. But pathological, we're looking at it to say it goes beyond what? 14 days. Then another point, we're saying the baby appears very sick. While in physiological, we said the baby is well. The baby is not sick in physiological jaundice. But in pathological jaundice, the baby is sick or very sick. Then in terms of treatment, we said physiological jaundice does not require any treatment. It will resolve on its own. While pathological jaundice would require phototherapy and exchange blood transfusion. Okay, so it will require phototherapy, meaning the use of light, and exchange transfusion. So now they also ask you questions to say what are the best treatment options for jaundice. So you'll be able to write in your completion to say phototherapy or exchange blood transfusion. So this usually comes in your completion part. They'll ask you about the treatment of jaundice. So you're going to put phototherapy and exchange blood transfusion as treatment for pathological jaundice. Sometimes they'll just say jaundice. So you need to master those: phototherapy and exchange transfusion. What will be the cause of pathological jaundice? So the cause for pathological jaundice will be excessive destruction of red blood cells. Then why would there be that? This may be due to infection or sepsis. Or there should be a problem such as cephalohematoma. So earlier on I said cephalohematoma, it's an accumulation of blood under the scalp. So when there is cephalohematoma, we're going to expect pathological jaundice. Other causes can be blood group incompatibilities, because this will cause hemolysis. And I earlier on mentioned to say another problem that can cause pathological jaundice can be an obstruction in the biliary tree. Okay, so this can be the cause. At least there is a problem. Then from there, let's look at other types. So the other two types that we have of jaundice, we have breast milk jaundice. So in breast milk jaundice, what you need to master is that there are particles or components or factors in. So don't mind about this first. Let's cancel this out, because this might confuse you, because even in the next type is there. So under breast milk jaundice, the main thing that you need to know is that in breast milk there can be factors. Okay, factors or chemicals in breast milk such as pregnanidiol, fat acids, or beta glucuronidase. These can be there. So if these factors are present in breast milk, they will slow down or inhibit the conjugation or decrease the excretion of bilirubin. So when they inhibit the conjugation, meaning that the child will become yellow. So this is found in milk, the mother's milk, then passed to the infant. So when these are passed on to the infant, you find that the infant will be getting this milk which has these things here, or these chemicals or factors. Then it will not conjugate its bilirubin, so it will be becoming yellow. So just that's what we say breast milk jaundice. Okay, so let's go to the next point, which is jaundice in breastfeeding infants. So jaundice in breastfeeding infants, meaning that the issue here is that a mother is breastfeeding, okay, but then this infant is having problems with just feeding itself, meaning that it may not be feeding well. Okay, so this infant may not be feeding well. So if the infant is not feeding, what will happen is that the clearance of bilirubin will be slow. Okay, so there'll be decreased hepatic clearance, or the clearance of bilirubin will be low because the infant is not feeding. So jaundice in breastfeeding neonates, meaning that the infant is not feeding. So the clearance of bilirubin in the body will be very slow, so it will be becoming yellow. So that's why mothers are encouraged to breastfeed their infants, so that at least they clear the bilirubin. Okay, so those are the types. So let's look at the investigations. The investigations, we've got what we call history taking. History taking, you may discover that you can look at neonatal sepsis, which is infection. It can show maybe the child has an infection early. Okay, so it can be neonatal sepsis or neonatal infection. Then under physical examination, what can you see as an examiner? What you see as a person examining this child, you see that the child is yellow. And if the child is yellow, meaning yellow maybe on the skin or the sclera, that's what it will show. Then when you do a blood test, you discover that the levels of bilirubin will be very high. So this is the blood test. Collect blood, then you discover that the levels are very, very high. Then another test will be urinalysis. When you do urinalysis, you discover that on the bottle there, just check, you discover that the levels of bilirubin will be very high. Or sometimes you can say urobilinogen will be very high. Okay, that's what happens. Another test you can do is a Coombs test. Coombs tests will be a test which will look at the blood incompatibilities. You discover that there may be some incompatibilities in the blood, so that's why the child is having this hemolysis and all that. That's when it will appear yellow. Then sometimes you can also do a full blood count. A full blood count may show you the high leukocytes. And what does it mean when they are high? When the leukocytes are high, it will show you that there may be an infection. So that's why the child might be having jaundice. So let's look at now the treatment. So under the treatment, like I said, there are two main ones, but let's look at other types of treatment. So other types of treatment here which we'll look at will be the non-pharmacological. So but before we go to that, what would be the goal of our therapy? So the goal of our therapy would be at least to lower the concentration of bilirubin. When we lower the concentration of bilirubin, meaning that we're trying to reduce its toxicity, or the toxic levels will be reduced. So the main types of treatment will be non-pharmacological and pharmacological. When we look at non-pharmacological, we're looking at just feeding. Now those babies, they don't have a problem. The only issue is that they are not feeding. Like we looked at jaundice in breastfeeding infants. So they are not feeding. So we need just to look at early feeding. So when there is early feeding, we said it will help out clear the amount of bilirubin from the body. So that's what non-pharmacological is about, just feed. Then we look at pharmacological. Why they say pharmacological? Because that's what we use in our medical language when something requires maybe treatment. Say pharmacological. Okay, so there should be phototherapy and exchange blood transfusion. So I said when you are asked, maybe in one word answer, they'll ask you about the main treatment therapy for jaundice. So the main treatment therapy or therapies for jaundice will be phototherapy and exchange blood transfusion. That's what we look at. So let's look at what we consider as phototherapy. Okay, so when you're writing your essay, remember there should be a part in your essay which should have phototherapy care. Phototherapy care should appear somewhere in your essay. At least this needs to come out, phototherapy care. Okay, so we'll talk about it. In your essay, at least it should come out when you've been asked to write your nursing management. Okay, so let's look at now phototherapy, meaning that we're using light here. So this is achieved by the use of light, okay, light energy. And then this light energy, what does it do to bilirubin? It will change its shape and structure, or it will change the shape and structure of bilirubin, thereby converting it to molecules which can be removed from the body. That's what happens. That's what phototherapy is doing. It's light energy which will change the shape of bilirubin, converting into molecules which can be excreted from the body. Okay, that's what phototherapy is about. Then if you look at it, so this bilirubin can be absorbed using ultra blue light. So that's the blue light you see in the hospital when you go and the baby has been placed there. So sometimes this baby can be nursed in an incubator while we are using at least light on top of the incubator. Then ensure that you are turning the baby regularly to ensure that all parts are exposed. Okay? Then what else should you do? Keep the eyes covered with a pad. So you are trying to protect the eyes, and if it's a boy, cover the testicles because they can be destroyed. Cover the eyes, cover the testicles. Okay? What else should you do? Monitor vital signs for hourly. Okay? So that there shouldn't be any deviations from normal, or you detect the onset of infection. Then monitor the mucous membrane, which is here. Monitor the mucous membrane so that you detect any improvement. Is the yellowness disappearing or it's still persistent? So that's why you need to monitor the mucous membranes. Then another thing, as you are doing phototherapy care, monitor for the signs of dehydration, because you're using light here, so the child is likely also to become dehydrated. Then another point which you have to monitor are the signs and symptoms of kernicterus. Monitor for the signs of kernicterus, such as irritability. So kernicterus, it's a complication. Remember, I said it's a complication of excess amount of bilirubin in the brain. So monitor for kernicterus. Then if the mother is breastfeeding, encourage the mother to breastfeed. So meaning that you're doing phototherapy care. Okay? Then what else should you do? You're going to inform the mother. Okay? Inform the mother about the therapy and explain what is going on to allay the anxiety. That's what you're doing there. Okay? Then occasionally what should you do? You need to hold the baby. Okay? And then promote baby mother bonding. So meaning you need to give it to the mother for bonding. That's what you do. Then you also encourage the mother to ask questions which are appropriate, so that at least you promote knowledge. Okay. Then what are the side effects that you also need to monitor? So you discover that they can ask you about the side effects of phototherapy, or even in multiple choice they can put the following are the side effects of phototherapy except, or you can just find a question to ask you about phototherapy side effects. So number one, there can be watery stools, which is diarrhea, insensible losses, maybe through sweating, okay, or even just insensible, just losses that you can't even see, sweating, sometimes even skin rash. So these are the side effects of phototherapy. So you need just to know them. So the types of phototherapy that you can have, we have the conventional one, which is just the ordinary one that we use. Okay, the conventional one is the ordinary that we use. We use just the blue fluorescent light. Okay, using lamps. So this is the one that we have. Then another type is the fiber optic system, meaning that we use what we call the Billy blanket. So this blanket is covered, cover the infant in this blanket, they need to wake. So we are done about phototherapy. So there is another type, another treatment type, we're saying exchange blood transfusion. So in exchange blood transfusion, we're trying just to transfuse and remove the blood which is there. So we're looking at maybe if, say for example, the problem is A or B incompatibility. So if it's A or B incompatibility, meaning that blood is removed. Blood is removed through the umbilical artery and fresh blood is put through the peripheral vein. So this is how it's done. Okay, so through the artery, the umbilical artery, okay, blood is removed and then fresh blood is put through the peripheral vein. Okay, that's what happens. Then there can be complications there. The Complications can be, the ones that you can have can be exposure, blood exposure risks, such as maybe you can even have HIV because they're trying to transfuse hepatitis or and all that. And there can be acidosis, hypoglycemia, or air embolism as you're trying to transfuse. Okay, so you need to put the child also on antibiotics to combat what? Infection. So that's about exchange blood transfusion. So those are the risks that we have. Let's look at now the nursing care plan. Sometimes you can be asked to write the nursing care plan on jaundice. So let's try to see what are some of the problems that you're going to identify. Okay, so you can identify the following problems. Number one, there can be altered temperature less than normal. So it can be altered temperature less than normal, meaning that the child can have hypothermia. Okay. Then other things in terms of other problems can be fluid volume deficit, meaning that the child is losing fluid, maybe through diarrhea or insensible losses. Then altered nutritional status less than body requirement, meaning that the child can become hypoglycemic, so you can have that as a problem. Then impaired skin integrity, we know that it can damage the skin, it can damage the conjunctiva. If it's in boys, it can damage the testes. Then risk of injury can also occur. So we can look at risk of injury. Okay, I didn't put it here. Okay, I didn't put it here for you, but I'll try and put it there next time, but didn't put it there for you. So this is the nursing care plan. So, but I'm sure you've learned about the nursing care plan, and obviously you know how to write a nursing care plan. So if you haven't learned how to write the nursing care plan, we'll be able to at least have a session where you can write the nursing care plan. Okay, yeah, so this is it, just a sample of what you can write. Okay. Okay, so we've talked about how to nurse a baby. So if they've talked about maybe you writing nursing management, under nursing management, remember that you need to write a heading somewhere. As you write your prophenema, remember that you should have a heading where it's a care of a baby on phototherapy, where we looked at protecting the eyes, protecting the skin, protecting the testicles, okay, and also monitoring things like diarrhea and also the vitals. Okay, that's what we looked at. Okay, then let's look at complications. If you look at the complications, number one, we're concerned about kernicterus. So we've talked so much about kernicterus. So kernicterus, it can lead to brain damage. And when we talked about kernicterus, I said it's the excessive accumulation of bilirubin in the brain. So this can lead to brain damage. Then again, the other issue is that they can say that bilirubin encephalopathy. Sometimes when they say bilirubin encephalopathy, they want you maybe to say, they might also refer it to as kernicterus. Sometimes they might want you to write like that, where they say bilirubin encephalopathy, meaning that they're talking about kernicterus. That's what they talk about. Okay, though we put it independently to say encephalopathy as a result of unconjugated bilirubin. So this might be the same. They want you to say it as the same thing. Okay. Then conjunctivitis. Remember, the eyes are being damaged. Why are the eyes being damaged? Because there is accumulation of unconjugated bilirubin in the conjunctiva, excessive amounts. Okay. Then cerebral palsy. This we're looking at accumulation of bilirubin also in the brain, excess amounts. Brain damage, excess amount of bilirubin again in the brain tissue. Hypothermia. Why should the child become hypothermic? Sometimes you might want to look at maybe say exposure to treatment as you are doing your phototherapy. Sometimes it might be that the child is not having enough uh, aerobic respiration. That's why the child might go into hypothermia. Okay. Then let's look at prevention of neonatal jaundice. So when you want to prevent neonatal jaundice, what you need to do, number one, is reduce the risk of having preterm babies. So just prevent prematurity. Okay, meaning that the mothers should be able to go for antenatal and be treated for any infections and eat well. That's the thing. Okay, that's what mothers should do. So you should go for antenatal, then be treated for any infections, then eat well. Okay, then take blood tests. When they take the blood tests, meaning that they will rule out what we call G6PD, okay, or G6PD. So this is glucose 6 phosphate dehydrogenase deficiencies, meaning that they have to rule out this problem here. Okay, this is an HB problem, or the sugar problem. Okay, whereby there's a reduction in this glucose 6 phosphate dehydrogenase. Okay, they have to do a blood test. Okay, then again, to prevent this, meaning that the mothers should be able to initiate breastfeeding as early as possible to prevent jaundice. So it's the same here. They have to initiate breastfeeding. And then how frequent should they feed? Okay, so feeding should be at least on demand, but should be at least 8 to 12 times in 24 hours. That's what's recommended. 8 to 12 times in 24 hours, meaning feeding is 2 hourly. That's what goes on there. So you need to feed, so you need to encourage feeding. Then expose the baby to light, meaning that sometimes, though there is a controversy to say that ultraviolet light does not convert unconjugated bilirubin into conjugated bilirubin, but sometimes they say try to just expose the baby to light. Okay, that's what they talk about. Then maintaining high standards of prevention of infection, so meaning you're supposed to prevent sepsis. Okay, so what are you going to do to prevent sepsis, meaning that you need to do what is known as cord care. Okay, meaning that you're not going to do cord care to prevent infection. Then other things that you're supposed to do is grouping and cross matching, meaning that for the mother who has a rhesus incompatibility with the baby, we provide anti-D immunoglobulin. So we give anti-D immunoglobulin so that we prevent A or B, or maybe say rhesus incompatibilities. So to prevent rhesus incompatibilities, give anti-D to the mother. Okay, that's what happens here. So I'm sure you've heard of anti-D, and that's what you give to the women. Okay, so this anti-D here, when we talk about anti-D, it coats the fetal red blood cells and destroy them before woman produces what? Antibodies. So mostly give anti-D to these women. So this is the end of the presentation. But what you're going to do is just learn the skill of writing these essays. So here it's not complicated. You're going to write a prophenema, okay, just the general care. But the only thing I'm emphasizing that you add here as you're writing a prophenema is care of a baby on phototherapy. You need to add it there. So thank you very much for listening to Mr. Coco, and keep studying. Thank you very much.